one we came across recently. So this patient had a leadless pacemaker system put in, and we've seen it's called the micro one that they put in the right ventricle.
Okay.
But if you look in this patient, there's actually a second device here, and this one looks a little bit different than the micro. It's a little bit bigger,
Okay.
um, but there's one in the right ventricle, and then there's this other one here. And if you look on the lateral view, there's some motion artifact, but you can see there's these two devices. So the Avere 2 is what it's called, and so this is a dual chamber leadless pacemaking system. Let's see, here's what it is here. So I took this from the manufacturer's website. So what's kind of cool is you can put in just an atrial pacer, just a ventricular pacer, or you can do the dual chamber pacer system here, depending on what you need. And they're actually upgradable, which I thought was kind of cool. So let's say you start with this one and then you need ventricular pacing. You can go add this one. You can put in this one here and then you can have them, they actually talk to each other. So they use this little protocol here. They call it implant to implant so that they can synchronize and that the two devices talk to each other. So that, and you can even add, when you add the second one in there, you can then hook them up together. So this is the Avere dual chamber pacing system, leadless pacemaker system. And they think they'll last like 9 years based on the previous ones, which is kind of good. So
Yeah.
I don't know the specific, like when you would do this over an implant, like a transvenous one, but it's something to keep an eye out for. It's the first one I've come across. Um,
Good.
this is a kind of an interesting case. We got this radiograph and we're like, that is a lot of coils and
Oof.
stents and stuff. So we were trying to figure out what had happened. This is just more of a wow, but we see stuff put in the chest all the time, but nothing like this. So good old CT here. This is just this patient is a repaired tetralogy of Fallot and has a pulmonary artery stent here, but they developed a massive pseudoaneurysm off this sort of the pulmonic trunk here. So this is what they ended up coiling, was this big thing here, which is a very large pseudoaneurysm. And clearly
Wow.
it's been there a while. There's some thrombus in it. There's some calcifications.
Yes.
So they just parked, and it was 13 coils they put in. It's a lot of
Wow.
platinum.
They just put in coils and put in coils and put in coils until they kind of figured they filled it up.
Yep. And this was a while back, and so far so good.
Yeah.
So that was kind of fun.
Jeez.
This is really this is a crazy something. So um, I won't tell the history yet, but
Okay.
this was one of our oncology patients,
Okay.
and I'm looking. You look at the lungs, and there's these nodules with halos, right?
Yes.
So you might think infection. You might think it's not. It doesn't have the quite the look of organizing pneumonia, but I could see someone. It looks like David has joined us.
Good.
Um, yeah, so you might think organizing pneumonia, they're a little more amorphous than that, and they don't seem to follow the lobular anatomy as much. So to me, this looks a little funny, but you wonder about maybe an infection or not. So this patient was on treatment for pancreatic cancer, pancreatic adenocarcinoma, and so they ended up biopsying these, and these are Mets. And
Yeah.
I've seen a couple of other cases of pancreatic adenocarcinoma give really bizarre looking metastases, almost mimicked interstitial lung disease because they became confluent. They can do not solid nodules, cavitary little Cheerio nodules, but these are sort of like this, people refer to them as hemorrhagic metastases, but they're not really because they look the same 6 months later or 3 months later. They don't all bleed at the same time. I think a lot of times those are tumors that either that generate a vasculature like an angiosarcoma or a choriocarcinoma, or that invade vasculature. I think this is just a weird growth pattern. And I don't have the details because this was a small transbronchial biopsy.
Okay.
But I suspect if we wedged one of these out, we would probably, maybe there's lipidic growth for all we know.
Yes. I agree. I
Yes. So
think that,
pancreatic adenocarcinoma with halos. All
yeah, I've
right.
got one or two cases like this that I can try to remember to show more florid, but otherwise the same kind of morphology.
take off. Anyway, this patient has these multiple chest wall masses. You can see here, and they have that incomplete border sign, so
Yes.
well-defined, extending outside the rib margin. So clearly something chest wall. And this is just a really nice example of, I can get the right, I always get the wrong, but there we go, of fibrous dysplasia.
Mm.
But it's more than one bone. So this is polyostotic fibrous dysplasia, which is usually, I think if I remember correctly, it's usually affects one side of the body,
Oh,
or at least
okay.
is disproportionate. But it's interesting. It's just these three ribs in a row here with that.
Right.
And so this
Is
was
there a
kind of cool.
syndrome that's associated with it? Does McCune-Albright sound familiar to
Yeah,
anyone?
yeah. McCune Albright, right? With the, I think it's the coast of Maine skin patches they get. I don't know if this patient had that syndrome or not. I don't
Right.
remember finding that, but yeah. But just
Yeah, I forget the details of McCune-Albright, but
yeah,
multiple non-ossifying
yeah. And
fibromas
I
is
remember
too
it's like one
benign.
side of the body's involved, which is very bizarre. All right, and then this last case, this is one I'm curious what you guys think. I don't think I've shown this one. If so, I apologize. So this patient has this funny kind of fatty mediastinal mass, and I think it's pretty academic. So the question is, and there's a little bit of tissue around it, is this a
Okay.
lipoma in the mediastinum, or is this a thymolipoma? Now, I know David has shown some thymolipomas are these big masses with lots of strandy
Yep.
tissue that kind of drape over. Um, I kind of get the sense this is probably a lipoma pushing some tissue over, but there's this one little septation here. Like I said, I don't think it really matters. I guess the main differential was is this a liposarcoma, but there was nothing really aggressive. My guess is it's a lipoma, and that's the thymus being pushed right there.
Yeah, hard to say. I suppose a low-grade sarcoma would come into the differential, would it?
Hmm.
Just because
There's
it
that
has
little
solid and other
right there.
components.
Yeah.
So maybe just it would be prudent to maybe a short-term follow-up,
Hmm.
just in case
Yeah.
it's something like that, perhaps.
Yeah, that's kind of what we thought. We favored it being whatever it is. It's probably benign. But I don't think it's a thymolipoma though. I think it's probably more of a
Yeah.
lipoma, less
Okay.
likely a low grade liposarcoma.
Yeah.
Okay.
Yeah. Yeah. Good.
All right. Those are my cases.
Okay. Let me just try to remember how to sign on here again. Let's see. Share and screen. See my database okay?
I do.
Good. So first case, no mystery to those of us that do a lot of ILD imaging, but I think nice for teaching purposes, so I thought I'd show this. This is a chronic smoker. So I'll scroll through the images top to bottom. And I couldn't predict pulmonary function tests from this. I wouldn't be surprised if it was a very mixed pattern, not just findings of expiratory airflow limitation, but also impaired DLCO and so on and so forth. So
Hmm.
the way I would just describe this in my report is something like findings are present typical of smoker's lung in the form of areas of pulmonary emphysema located primarily in the upper lung zones, and a diffuse pulmonary hyperattenuation abnormality consistent with the pulmonary accumulation of smokers' macrophages and possibly also smoking-related interstitial fibrosis. And then not a dominant finding, but there is a small area here of subpleural cystic change, maybe some reticulation. Not a dominant finding, but perhaps that's enough to at least raise the possibility of some fibrosis in the lower lung zones, as in combined pulmonary emphysema fibrosis, but that isn't really a dominant finding. But there is some basal reticulation. down here as well. So that's the way I would describe that. And then if someone said, oh, DIP, I would use the opportunity to say that finally we have an updated classification system. Let's see if I can get that, in which finally they have replaced DIP. They've done several things, but they replaced DIP finally with AMP, alveolar macrophage pneumonia, and it's really alveolar smoker's macrophage pneumonia. So I would take the opportunity to talk about that, and we can use the term alveolar macrophage pneumonia. But that's how I would describe or report that particular exam. Would you do it pretty much the same way?
Yes, so if I think it's smoking related, I'll say that and then kind of then get into the details of the subtype. Is it emphysema predominant? Is it, macrophage slash RB predominant? There's some smoking related interstitial fibrosis? But yes, I try to put it under the umbrella of smoking related diffuse lung disease.
Yeah.
That's
And
the
then
one
if they,
thing
yeah, go ahead.
go ahead.
No, if they ask me, well, how do you know there's SRIF in there? I would say, I don't know there's SRIF there, but we can't make a distinction on imaging between the diffuse background hyperattenuation abnormality due to macrophages and SRIF, or both. And both may be present, but I can't even really speculate how much, for example, SRIF there may be in there. But that can produce this diffuse pulmonary hyperattenuation abnormality or ground glass opacities.
But I think there is some bronchioloectasia in that fibrosis in the right lower lobe. So I think the fibrosis is really there. Yeah, I mean those bronchi are dilated down there.
A little bit down here.
Yeah. So I think that indicates that there really is some fibrosis. It's not just all macrophages, but fibrosis too.
Okay. Yeah, I'll try and bring that out with a MINIP image. When I show cases and I want to highlight that fact, I'll convert it to a MINIP. This is a 4 millimeter minimum intensity projection to show the bronchi and then more distally the bronchioles that stand out rather nicely like this, for example. Yeah.
That brings it out nicely.
Yeah. Yeah, very nicely. Excellent. Okay. Here's sorry, go ahead.
I was going to say that, yeah, the one thing I really like about the new classification system is they finally did get rid of DIP. There's a lot of things I don't like about it. I think they even made it more complex and confusing for a lot of people. But I do like the alveolar macrophage pneumonia, or well,
AMP,
getting rid of the DIP part. Yeah.
Yep. Yeah.
So Howard, could you send that article or post it? Because I'd
I'll
like
send
to,
it out. Yeah. Just without getting too far into the details, they have really tried to replace HP with something they call bronchiolocentric interstitial pneumonia, both the non-fibrotic and the fibrotic variant. I kind of agree perhaps with the fibrotic bronchiolocentric IP replacing fibrotic HP, but not so much with the other. And I will tell you that there were 4 committee members that, and they describe it in the article, that withdrew their co-authorship because they disagreed with that, including David Lynch, maybe another radiologist, 1 pathologist, and 1 pulmonary physician withdrew their co-authorship status in kind of protest at this new BIP discussion. But I'll send it to you so you can read about that. It's interesting.
Yeah, we have, when I showed this to our pulmonologist, and they kind of made the same kind of comments. It's kind of it doesn't help, and it makes things more confusing. And we have not adopted this BIP, and I don't think we're going to.
Yeah, I am somewhat sympathetic to the fibrotic BIP, but I'll send the article out and you can see what you think about that. It's a nice cute case in a patient. Let me make sure it comes up correctly. So let me show you two radiographs, time X and time Y. So here is one from 2016. The patient has had a sternotomy. And one from more recently, if I can get it in the right order, something like well, I'm going to show you a lateral from here. And I'm going to show you, because I can't quite see where my frontal is, but I'm going to show you a sternal radiograph, but I'm going to show you the lateral. I will tell you that the report of the chest radiography and the report of the sternal radiography just said intact sternal wires. And that's pretty much it. Now, they didn't really get the history, but there is a finding here. And that relates to this most inferior sternal wire, where you can see this twisty portion now is directed anteriorly as a change from before.
Mm.
And I really want to get the lateral. Okay, here it is. Here. Because if you look at this carefully, you can also appreciate, and I will make this bigger, that associated with this pokey wire is this. So there seems to be a soft tissue lump, and easy to imagine a patient reporting a painful lump like that with that. Now, that wasn't observed as such, but it is a change. And I know I've seen this once before. I do not know why this wire has straightened out and approaching the skin surface with some soft tissue component. I'll show you the CT for comparison. Let's just go for this one. You'll be able to appreciate when I get down here that there is indeed a fluid, localized subcutaneous fluid collection about and a bit inferior to this wire, this painful area. And here's a nice correlation with the surgery. Findings, there was some inflammatory tissue that was removed and the wire came out without an issue. Interesting. I don't know why that happened.
Yeah, weird.
Sorry, Jeff, I think your voice disappeared.
Oh, can you hear me?
Now I can hear you.
Oh, yeah, I thought that was really weird, just how it did that.
Yeah, no idea.
It said she
No
lost a
idea.
significant amount of weight, so maybe that had something to do with it, but that
Oh, I don't know.
But why would it move a wire? I don't know. Well, we saw something interesting recently. There's a new closure system. It's called fiber tape. It's
Hmm.
like it looks like dental floss. I mean, and they can close the sternum with it. It's a really cool. We found a video online showing how they do it. They were showing a live case, but the problem is you can't see it on the radiograph at
Oh,
all. But the thing is, you don't have wires in there anymore, so you don't have this problem. But the one question I have is, well, how are you going to recognize a dehiscence, at least on imaging? You're
yeah,
not, but
yeah.
yeah, it's but instead of using wires, they just they and then they wrap it. They kind of do it like they would do with the wires, and there's a little device that just cranks them really tight and pulls them together.
Oh, I know, I haven't seen that yet.
Yeah, I can't show a case of it because there's nothing to
Yeah,
see.
yeah, yeah. I suppose if you have substantial dehiscence, you would have to be able to see a widening of the
Right.
sternal incision.
Yeah, you could pick it up on
Or
CT, but
yeah,
but a lot of times it's not suspected clinically, at least right away. So
yeah.
yeah, we've seen some. I've only, wire problems aren't that. I mean, they're pretty common to see wires, but we don't see that many problems. We see fractures. We see sometimes they have to go in and remove some of the wires. Um, but yeah, that's weird how it moved like this. Something must have had to
Yeah.
push it.
No idea. did somehow the inflammation ensue and then the wire straightened because of the inflammation around it, because of some tension? I have no idea. Just complete speculation.
Yeah. There'd be some serious tension.
Yeah. But
Interesting.
took the wire out, and I'm sure she's going to be fine.
Yeah.
Okay. So this is a lovely case. So I have a nice relationship with a pulmonary pathologist. Sometimes she'll send me nice images based on consultations that she does from the outside. So this was a case that was sent to her with imaging, but also the pathology from another place. And then she sends me the PowerPoint, and then I contribute some images, and we have some nice pathology and radiology. So let me show you. Yeah, this one depicts it rather nicely. So two dominant findings here. The first, there are these strange opacities in the lung apices in the anterior upper lobes, just up here, rather large, but just like that up there. And then the other very dominant finding is tremendous thickening of interlobular septa, a little bit asymmetric, right more than left, but these septa are very, very thick throughout the lungs, to a lesser extent down here. And then we also have pleural thickening or apparent pleural thickening. So let me show you that on the coronal, which shows that's a MIP. So let me get another one. That pleural disease here as well. So the two dominant pulmonary findings and that. So, I asked folks, what would you think of if you have findings like that? Oh, I'll go back to this just to mention one thing, and that is, people reflexively say, oh, if you have septal lines, then you have lung edema. Well, we don't have peribronchial fluid cuffs of water in the upper lungs. Debatable, and I think it's possible that we could have subpleural interstitial edema, but we don't have pleural fluid as such, and the heart's not big. So there are some findings, and distribution-wise, to suggest this is not plain old interstitial lung edema, but some other process entirely. Part of imaging was done, so you'll see that we have, no surprise, that these large opacities in particular, FDG avid, you can see there, and some other regions are FDG avid. So there's a differential diagnosis for that, but certainly one thing always comes to my mind, and I think it would come to David's mind in particular, because we like that topic. But any thoughts? Information we have really is not contributory to this, but it's not cancer.
Well, I mean, you can get alveolar septal amyloid. So if they're, and the FDG uptake would be from plasma cells.
Yeah.
Something
It's
else.
odd
I mean,
that,
I've seen storage diseases, but I expect it to be a little bit. I mean, 76 is kind of old for even
Right.
adult onset storage disease. Amyloid
Right.
would be high on my list, actually.
Yes, very much so. Exactly right. Beautiful case of that. So let me just fix this up to make black and white. And here we'll have some really nice images. There's the history. CTs were done, then ended up with a biopsy. I just put the radiology findings in there for my colleague. And pointing out alveolar septal, these would be considered alveolar. They may not literally be stuff in the aerospaces, but anyway, consolidation like, and then septa. Yes. And then here we have, now I can't point out, because this is so extensive, I can't actually point out an interlobular septum among everything else here, but there's a lot of pink everywhere. Some regions that are more focal, but tremendous amount of pink staining amyloid. She did wonder whether true pleural thickening is present, because in pathology, she said, actually, we think we see a lot of subpleural disease rather than pleural disease. I say, okay. No surprise that we can also get amyloid deposits in vessels under the microscope. Congo red, birefringence, very classic. Here's some giant cell reactions. Now, a little bit off tangent, but I think this is kind of a nice reminder of how, unlike in this patient, we can get cystic lung disease and emphysema with amyloid, which this person doesn't have. But this is fairly important in terms of the pathogenesis of cystic disease if you have it. And I say, first of all, we have tissue macrophages, histiocytes, they are synonymous. So tissue macrophage and histiocytes are synonymous. When they fuse, they become giant cells. And then go through the discussion of lots of macrophages accumulating around amyloid, upregulation of matrix-associated matrix metalloproteinases, and those are the enzymes that degrade lung substance and may produce cystic lung disease. So anyway, a nice one image of giant cells accumulating about amyloid, trying to gobble it up. And then we presume this is AL. They're going to send it out, I suppose, for mass spectroscopy to define the substrate for the amyloid. But super nice case, yeah? Alveolar septal.
Yeah.
Very nice. Yeah.
Yeah, very nice septa particularly. Kind of strange why the large opacities formed in the lung apices, but that's just random, I suppose.
So I think I've seen one case of septal amyloid where it was worse in the upper lungs, as in your case here. I think most often you see more of the septal lines in the bases, but I do have one that, like this case, is really concentrated in the upper lungs.
Yeah. Yeah. Don't know why, it's just a random.
Yeah.
Undoubtedly, there's amyloid all in here too. Yeah. Yeah, very striking. Is it Erdheim-Chester that sometimes can produce lung disease characterized by very thickened interlobular septa?
Yeah.
I think so. Those non-Langerhans dendritic cells accumulating in the lung.
And going along with the macrophages causing emphysema, we did have one case that had a lot of subpleural infiltration with Erdheim-Chester in the upper lungs, and that person eventually developed paraseptal emphysema. That's the upper lung distribution right out against the edge. So I think once you get macrophages in the lung, they're going to make holes in your lungs. They're not.
Yeah, they may
they're
make
not
holes.
your friends. Yeah.
So this is the case in follow-up that I showed you folks, just a very dramatic case. You can see it's a young person that developed or presented with lots of pulmonary opacities like that. And hard to describe other than being multifocal, multilobar opacities and very dramatic CT. So this goes back to 2024. Of course, I'll show you, and I'll put that one, as it turned out, we have a comparison with the current one, which I'll put up alongside it here. And, let's look at these again and kind of scroll through this. Something like that. We'll go up here. To show the nature of these opacities just in the macro sense, and to show how much progression has occurred in the interval. Particularly large opacities have developed in multiple places. Areas of cavitation have developed in multiple places. Just a progressive disease, very substantially so. To go back to the earlier one, I sent this out because I certainly noticed the presence of Cheerios, lots of small nodular opacities in multiple places with areas of cavitation within. So Cheerios and larger opacities and areas of cavitation. And certainly, even though he's a young person, thinking about the possibilities, I was worried about adenocarcinoma, which we can see with Cheerios, and obviously multifocal, multilobar disease. Later on, we got a history, as I'll show you in a moment, after admission, that he was diagnosed apparently with Cocci in 2018, treated, but we don't know details about the treatment and its duration since 2018. But that certainly changed things. But I'm not sure I've seen Cocci produce so much disease and Cheerios like this. It can do strange things. But that is indeed what it has turned out to be. So we had lots of serology like these with very high levels of Cocci-associated antibodies. Did have a culture which ultimately did show Cocci. No malignant cells on the biopsy, granulomatous inflammation, some granulomas. Pretty dramatic. Have you seen a case with this particular appearance?
No, and I mean, this looks like we talked about this. This looks like adenocarcinoma.
Yeah, sure does.
And so, Howard, initially, didn't you think the possibility of mycobacterial disease too?
I just threw that in there because I was struggling to come up with with other things.
Yeah.
So if I threw that in, I did, but not for a good reason or other reasons. I was just trying to think of chronic conditions with cavitation, progressive.
I don't know, Jeff, do you think that would TB cross your mind on the initial presentation?
I mean, it could, but I mean, TB does a lot of things. I would expect the patient to be pretty sick though if this were all TB.
Yeah.
And usually, you often see more stuff in the airways, like tree and bud, but I think TB is reasonable.
So we've seen a number of cases of Cocci that people's first thought was TB. So I don't know, tangentially, this case may be a similar example, but I didn't chime in when Howard first posted this case because I couldn't really tell what it was, but I thought adenocarcinoma was very plausible. When I first saw it, though, I did think of the possibility of TB or atypical mycobacterial infection.
Yeah.
Because it seems to be spreading in the airways. It's got an airways kind of dissemination pattern, and it's got cavitation.
Yeah.
And this patient had no risk factors for, I mean, you can get severe Cocci even if you're otherwise healthy. It's just
diabetes.
This is going on for
exposure.
Yeah, this is going on for a long
area.
time.
Yes.
Yeah.
And diabetes, and they seem to, someone somewhere said, oh, this looks like bronchiectasis, we're going to work him up for CF, and they arranged to work up for CF because they perceive this as being bronchial dilatation. I do not know why. And then he was perhaps lost to follow-up or didn't return, hence the interval between March of last year and now. So as best I can tell, yeah, pretty dramatic.
So was there any lymphadenopathy?
Yes, there is some. So I'll show you that. Not super dramatic, but yes, there are some nodes here. And the EBUS did show some granulomas, but the stains of the material from both the EBUS and the transbronch that showed granulomas didn't actually show, like the GMS stain, the actual organisms. But this is the extent of the lymph node enlargement. So yeah, kind of modest. Like that. Not super dramatic, but yeah, some. And some of these were a bit bigger compared to last year, a little bit. Yeah.
Crazy case.
Crazy case. Okay, Jeff, those are my cases for this week.
Thank you, Howard. David, do you have anything to share?
I do, if I can figure out how to do it.
I'm going to
our conferences are so infrequent that I don't remember from session. Okay, so this is the good old days. This one had nice clear lungs, and then she fractured her ankle rather badly. And then a couple days later, she had confusion and shortness of breath and had this radiograph.
As an outpatient, huh?
Yes, as an outpatient.
Ooh.
And then she had a CT scan, and it shows a nice ground glass abnormality with some sharp definition, some geographic margination to it, sort of mid and upper lung predominant, some accompanying pleural effusions. Okay, and a little bit of septal edema here in the bases. So this, confusion and shortness of breath raised the question of septic, it's not septic emboli, but fat emboli syndrome. And the as every experience I've had with orthopedics people, when you mention that possibility, they say, well, there's no way that could be operating in this case. And yet it often is what things turn out to be. Now, there are some tests that you can do for that. One of the things you can do is you can look in the retina and see if you can see little fat globules going through retinal arteries. That's one thing that can happen. So I asked the resident, I said, well, look up fat embolism syndrome. And so we went to Radiopedia, and the case that he came up with, their example is just a slam dunk copy of what we're seeing here. This ground glass abnormality, the same sort of distribution, the geographic margination, mid and upper lung predominant. And the setting of confusion is, that's fairly common with this syndrome.
Mm-hmm.
So this woman did not do well.
Wow.
And she eventually succumbed. There was never any demonstration of infection or other causes of her diffuse lung disease, but she died of hypoxemic respiratory failure. So fat embolism syndrome. So what happens is that, you mobilize little globules of fat, and then there are some metabolic changes with that fat when it arrives, and it gets broken down and it liberates fatty acids, which can be extremely irritating. So it's probably the fatty acid that causes this lung toxicity.
Yeah, it's unusual because it's usually, I mean, it all fits. It sounds like I don't have any question about the diagnosis, but it's usually younger patients. It's usually long bone, like femur fractures. And the cases that I've all seen have happened post-op when they put a rod in the femur or something, or it's,
I've seen it with spine surgery where they put in just, they put in like 160 pedicle screws. So you're mobilizing a lot of marrow when you do that. And, but I've seen, the orthopedists have denied that that's a possibility for their patients being short of breath and confused and stuff like that. Usually it clears up in a few days and people get better. This one did not have that.
Wow.
Did not have that option.
Yeah. I have never encountered such a severe and fatal case in my entire career. Never. That's just.
I think we have better trauma out here. You guys are maybe you're gentler.
No, those small fractures down there with such a bad outcome, that's just.
I think, probably some of it depends on what happens once you're fractured. I mean, was she walking around? Did she do something that mobilized the marrow? She's got two bones involved down there, and you kind of wonder what happened to her. In the meantime, they didn't. I think they put her in a cast. They did not operate on the ankle at this point, so she never really had surgery. I think they probably were going to do that later. Sometimes they wait a week for these ankle fractures, and then they go in and plate them. But she didn't get that far. Okay, so the Radiopedia example looks just like this. Go ahead. What were you saying?
No, I'm still utterly perplexed by the outcome.
Yeah. Okay. So this is a different patient now who recently had this defibrillator placed. Here's the pulse generator off in the lower axilla on the left, and then a subcutaneous electrode to the right of the sternum at this point, and a biggish heart. And then this person had coronary bypass surgery, and this is, I think, just before the surgery. I think at this point there's edema. And now they put in some sternotomy wires. This is the first exam after the surgery. We still have an ultrasound probe in place here for cardiac monitoring. And notice that the configuration of this lead has changed. Formerly it was nice and straight, and now it's got these ripples in it. So it's got two ripples and it associated with sternotomy wires. So when I saw this, I thought, these sternotomy wires probably grabbed the electrode.
Mm.
And so, I got in touch with the surgeon and mentioned this possibility. He said, thank you. And then, so I assumed they dropped it, but he contacted the electrophysiology people and they found that this lead impedance had changed. It was too low. It was like less than 30 ohms, which I think means that the thing is grounded out or is incomplete or something like that. I don't know exactly what it means. So I figured that just out of, embarrassment and concern, the surgeon would want to go in and remove these wires and free up the lead. But that's not what people decided to do, and I think they decided on something much more intelligent. So what do you guys think they did to solve this problem, or planning to do?
I don't know.
They decided that the patient didn't really need the AICD anymore and just snipped it off and discarded it.
They plan to discard the lead and replace the lead. So they're going to put in a new one, okay? And they're just going to let this one go. So that's actually a much better solution than removing the wires, because chances are the wires have damaged this thing
Yep.
anyway. So doing that would, you'd just be trying to erase this unfortunate little event, but that isn't going to really solve the problem. You're still going to have a defective lead. So just abandon the lead. It won't bother anything, and put in a new one eventually when the person is better able.
Yeah.
So we were talking about sternotomy wires earlier today. Here's another example of sternotomy wires, having unintended consequences. So that was interesting. So this little ripple here, it was real, and it was electrically confirmed that there was now a defect in the impedance of this lead.
Yeah.
Okay.
I'm trying to think this is a subcutaneous lead, so if you just got the sternal incision, that lead is really superficial. When
Right.
you put in the sternal wires, isn't the sternum visible? And how would you grab?
Well, I
On one
think
side, they somehow grabbed the superficial wire in spite
it's
of.
it's a little to the right. Here, you look at
It's a little to the right, yeah.
it's right of the sternum. So if their incision is here, this might not have been visible to them, because I don't think
Okay.
and then they put in the wires and they make them, go around it. And so
Oh,
they didn't see it. This was all in subcutaneous tissue, and the wires came out the subcutaneous tissue and they looped them around. I think would be pretty
oh,
easy to do that.
okay.
But not being a surgeon, I don't
Yeah.
know. Okay.
Okay. Yeah.
Okay. And this
Well,
is my last case of this. This woman, I think, has an oncologic issue, and for some reason, I don't know whether she's AML or MDS or something like that. And maybe pre-transplant, I think pre-transplant was neutropenic at any rate, and then had that steadily worsening radiograph. Let me lead up. Here is fairly normal right apex at this point. We do have pleural effusions and basal consolidation. And then she develops some cloudiness in her right apex. It looks as if something is brewing up here, pretty ill-defined. And it got still there, and it got CT'd. And I can show you better images here. I thought I could. Okay. So we do have this big blob up here.
yes.
And I can probably give you better images than that. Here are better images.
Yep.
So we've got this dense blob, and then we have some surrounding ground glass. So it really kind of shouts fungus. But they did everything they could to try to diagnose fungus. They didn't find any galactomannan or something like to implicate aspergillus. They did bronchoscopies. They didn't get anything out of this. She does have Pseudomonas sepsis. So the assumption was this must just be part of her Pseudomonas. But I don't think I've seen Pseudomonas as a round blob before. So with round blobs, we think of fungus, and
Hmm.
when it gets to be peripheral, we
Nocardia.
start. Yeah, and we also think of nocardia. So I like to throw that one in, and you've shown some spectacular cases of that. And especially for an apical lesion, that's really good for nocardia. We see that was sort of the favorite location of nocardia that we saw in association with solid organ transplants, like kidney transplants or heart or liver transplants. It likes to be in the apex. So that was a possibility. She did not have chest pain to suggest that there was invasion of the parietal pleura or chest wall. Um, and eventually they did a needle biopsy of this thing. So they hadn't found mucor, they hadn't found aspergillus, they didn't have nocardia. Another cause of a round pneumonia is Legionella mcdadii. So that got mentioned. And this turns out to be just another case of Coprinopsis cinerea. So you're all familiar with this organism. It's a fungus, and you can eat it if you want to. It's a little purple capped fungus. I did see a picture of it. So this is just another weird fungus, and it's rarely a pathogen for people. And what it is, it's usually in somebody who is immune compromised. So another weird organism here, another weird fungus that I'd never heard of before. So,
But they have
yeah.
the same. But the important thing, David, is that when you see these big blobs, it's usually fungus or nocardia or the rare
right.
bacterium. But
Yeah,
something to keep in mind.
yeah, yeah. I mean, fungus was the top of our list, and particularly mucor. But this was more indolent than mucor. I mean, that was the one thing maybe that, but I think she was she was on antifungals. So that can slow down the course of something like mucor or aspergillus. Sometimes aspergillus is not completely treated by the agents they use to suppress, like posaconazole, but it can
Mhm.
slow it down. So the slow course was a little bit of an argument against mucor, but you know, it turns out to be, it looked like fungus and it turns out to be fungus. So that part is reassuring. And
Yeah,
nocardia was high on the list too.
for sure.
Okay. So Coprinopsis cinerea. Coprinops. I had to practice that.
Nope, that doesn't come to mind. There you go.
Okay, here it is. I think this is actually the best view of it, isn't it? The coronal. Okay, guys.
Thank you.
Thanks. Good talking to you.
Yeah,
Yeah.
it's nice to have the conference again. Thanks for coming, Howard. Appreciate it.
Yeah, I'll try.
I'll be here next week, so hopefully we can
Pick it up
reconvene.
again. Okay.
Yep.
See you guys.
All right, take
Thank you.
care. Bye.
Bye, everyone.